Good evening, everybody, and very welcome to Rural Onboarding. We're actually in our 4th week already, and I see we already have more than 50 people on the call tonight. And it's been amazing to see the excellent attendance at these different webinars. And we've also noted many people actually watching and catching up if they're not able to come on the evening. And we are very pleased this week to be moving on to adult medicine, which makes quite a large bulk of what you're doing in OPD and in the wards, in sort of a district hospital setting or in a general practice setting in your rural area. And I'm very pleased tonight to welcome Prof Parrish, who is here from broadcasting from the Eastern Cape. We're both here in the East London area. And Prof Parrish is an Associate Professor of Internal Medicine at the Walter Sisulu University, and also an Honorary Associate Professor in Internal Medicine, Clinical Pharmacology with UCT. And he's based here at Cecilia Makiwane in Frere Hospital in East London. He's co-chair of the National Essential Medicines List Committee. So if you've any questions about what's brewing in the EML, and the chair of the NEMLC Covid Committee. His interest includes EBM and knowledge translation, and his various degrees are listed down there below. And Prof Parrish has been very passionately involved in training in our rural areas, and him together with Dr. Dave Stead and Dr. Jenny Nass has actually had a discovery grant for the last 3 years for something called BAMSI, which is specifically a project where the local regional tertiary hospital has been providing outreach and support for our local rural hospitals here in Amatola and BCM. And they started that project just before COVID hit. And there was big plans in terms of visiting sites. But actually, with COVID and the arrival of Zoom, it's made it possible for them to, as well as providing on-site support, they've also been providing an amazing webinar series program that they have been providing on a weekly basis for our local rural doctors. And in the medicine, tomorrow, I'll be sending you an adult medicine resource pack for all the Redasa members. And in that pack, I will put the link in for BAMSI, and maybe let me see if I can put it on the chat tonight as well. And very worthwhile to go and look at that website. And there's a host of excellent webinars there on a range of topics relevant for adult medicine in the rural district setting and some other areas besides. So thank you very much for Parrish for joining us. We will have a poll at the end, but I know the poll is sometimes problematic. So please also just put your names and MP numbers in the chat so that we can be sure to capture you if you would like CPD points for tonight's session.
Hi there. I'm going to stop my video after saying hello simply because of internet stability, but it's great to be on this just now. Madeleine, is that sharing?
It's starting. I'll let you know when it's on.
Madeleine, have I got a live share?
It's brewing. It's brewing. It just says has started screen sharing. It's not yet opened. There we go. And it's perfect.
Okie doke. Good. All right, then let's get going. And it's great to be chatting to a group of folk from all over the country. So very welcome to this session. And I hope you have a bit of fun as well as learning something. Madeleine was very brave in the sense that she sort of almost gave me a carte blanche about what I could talk about. So it's going to be a bit of a roller coaster. I hope there'll be something in there that you find interesting and useful. And the idea really is to cover a bunch of stuff that I've found useful over the years, and that when I worked in a rural area, it sort of struck me that these were things that are often not taught as well as they could be, and sometimes do make a difference to patients and how we manage them. So I'll get stuck in. The basic thing really is that we're going to talk about clinical security, the history and exams, and thinking about how we make diagnoses and decide on management. Few words about time management in terms of how you can cut some corners here and there and otherwise shouldn't. And then obviously the idea is to achieve excellent practice in a situation where you've got resource constraints, recognizing value, and really accepting that sometimes the patients in the textbooks are very different to the ones in front of you. So it's worth thinking about these things. What we're really going to look at is a bit of a roller coaster of stuff. There's a little bit about examination, and then I'm just going to bounce through some very common medical topics. I know that some of these have been covered. I'm going to not redo anything, but hopefully just float through some things with a few tips here and there. So let's hope you enjoy it, and let's get going. The first part is our advert. You all should know about the National Essential Medicine List. The problem with it is it used to appear as handbooks, and nowadays it comes electronically, and the electronic thing has its hiccups in terms of contracts and sort of IT. But if you're looking for versions that are reasonably up to date, you should be able to find them on the Knowledge Hub, and you go to eLibrary there, and basically the stuff should be available if you just scuffle around a bit there. The idea that we've changed is, instead of producing printed handbooks every 3 or 4 or 5 or 10 years, we now will update stuff on the basis that if we have a meeting, a quarterly meeting, then the updates should happen every 3 to 4 months. So we're trying to keep you as up to date as we are. This is where we hang out in East London. That's Cecilia Makiwani Hospital. But I just wanted to, as Madeleine's already mentioned, just introduce you to the concept of BAMSI, which is really in-reach and outreach put together with a video spiel as well. And this is our website, which has got a knowledge base and also some other bits and pieces you might be interested in. There's the address if you want to have a look at it. It's Medival without an I. It's not medieval. I'm just going to start off with some stuff about clinical examination. And this is a thing which you've all seen in patient notes. And it says S1 and S2 present, no murmurs. And it really is a reminder of how far our clinical examination can sink when you basically say halfway through clerking of a patient that the patient is still alive because they've still got heart sounds, and there's nothing else about the heart. When I do echo series every now and then, we get these patients and who have clear echocardiographic evidence of valvulopathies, for instance, and you look back through the notes and see 3, 4, 5 different clinicians all denying the existence of a murmur that's 3 or 4 out of 6. And that really is a fascinating but very real phenomenon, which I want to explore a little bit. So the first and second heart sounds are complex sounds. It's difficult to say whether they're normal, although everybody's happily will do that. I struggle quite a lot sometimes to know if it's normal. The second sound moves, and it's worth reminding yourself that it gets wider when you breathe in, and knowing about that and knowing when it doesn't get wider and what causes that is a useful clinical tip, but I won't spend longer on that. I will really move on to sort of just a comment on the pseudo-clerk, which is really something that we all are aware of. We've probably all done to some extent, and it's something that is to be fought against. It's ritualistic, it's stereotype, and one tends to just sort of pretend that you've done it rather than actually do it. It may or may not record the things that are essential for that patient's management, but it nearly always has got potential for missing stuff. And the other problem with it, particularly in a rural and less sort of tertiary center undergraduate space, is that people don't look over your shoulder, and so there aren't particularly any consequences unless you and your colleagues take it on and try and tidy up the space. It can be done, and it is worthwhile. The issue of why we miss these loud murmurs is fascinating, and there's a performance gap. It might be a bit of sensory inattention. You get distracted when you're listening to the heart by another patient who's fitting in the other side of the wall. It might be that your technique isn't right, or it might simply be that there's a bit of focus on other issues at the time. Sometimes it's a problem with people believing that they won't hear sounds and then going into that audiological space with a belief that these things are beyond them, which is not the case. So it is worthwhile thinking about your most of them are fixable. That's the murmur for you of mitral regurgitation. It's loud, it wants to be heard. So listen for it, and you'll be surprised how often you'll hear it. So here we go. There's the same thing from America showing exactly the same thing. You know, test scores of 60% for hearing good stuff in terms of cardiac examination isn't great. And cardiology fellows do a little bit better, but really not wonderfully. It is an area we can always hope to improve on, and it is certainly something which I believe is achievable, and I've seen it being achieved by folks. So try and see what you can do. General examination of notes, you know, a recording in the notes is also not always up to scratch. This is a Middle East study where 95% or 92% of cardiac examinations and general examinations were incomplete, not the way they would have been done as undergrads. And that reflects the fact that we're moving faster. So when you've got a huge herd of patients to see and you're busy and life is not being kind to you in terms of other stressors, it's appropriate to take shortcuts that make sense. The issue is if those shortcuts end up leaving us not covering things that we should cover. And that's just a question of awareness rather than a question of not doing any shortcuts. But the problem with these things is that they do have all sorts of consequences. Apart from the consequences for the patients, there's also medico-legal issues. So if your notes are less than would be expected of a reasonable clinician, it is possible to impute into that your skills might be less than those of an average clinician. And all of these things impose risk on both our own practices and on the health systems in which we work. So try and tidy up those notes, and you'll be surprised at how good it makes you feel. The other thing is that it is a team approach. You know, if one works as a group and everybody goes around telling each other that their notes are better, it does actually rub off on each other, and it can be noticed that other people are looking at your notes, and it all sort of does work towards things. If telling everybody else their notes are dreadful obviously isn't a great approach. So let's move on to some more fun things and start by talking about a clinical scenario, which is a 45-year-old man with swollen legs and shortness of breath, who's obese, he's apyrexial, and he's hypertensive, nosed. And as happens in casualty, you look at the x-ray before you look at the patient, and it doesn't help very much. And you think about various possibilities. Has he got a cardiomyopathy? And if so, is his ejection fraction preserved or not? Has he got a valvulopathy, in which case ACE inhibitors might be harmful if he's got a stenotic lesion? Or has he got cor pulmonale, same problem? Or is in fact a pericardial problem, in which case all of the medicines that you throw at him will be harmful other than pericardiocentesis and treating the specific cause, which is often TB. And how can we sort all this out? But just to give you some thoughts on a few issues, let's start with blood pressure. Now, as you know, a young person with at risk of all sorts of things, from coronary heart disease to stroke and other sort of cardiovascular events, including renal disease. So trying to sort it out is an important goal. And there are a few things that are worthwhile remembering. If you're looking for certain things in blood pressure recording, you will miss aortic regurgitation if you only use electronic devices. You'll miss the wide pulse pressure if the machine doesn't detect it for you because it's working with a different algorithm. You often find that those electronic machines aren't accurate at the extremes, so very high and very low blood. Quite a few of them, particularly the ones that haven't been calibrated for a year or three, can be very far out, as in 40 to 50 millimeters of mercury out. So keep an eye on that. And if you have the facility to get folk to calibrate your machines, do try and get that to happen. And then remember that if you are just taking blood pressures as a normal thing in a clinic, you want a sitting patient with a supported back, who's got a cuff that's the right size, a bare arm, a quiet room, hasn't been smoking, has an empty bladder, has had a chance to relax. And it's only then that you can say that you've done a reasonable job of getting the representative blood pressure for that patient. So I'm going to mention sprint because everybody talks about sprint, and I don't want to spend too long on it other than to put it into a slightly rural context. So sprint was this trial that looked at quite tight blood pressure control using machines and doing all sorts of good things in terms of getting the readings. But important and statistically significant reduction in primary outcome, which was a combination of events, and also showed a reduction in mortality. So everybody got extremely excited about it. Since it's come out, another trial or a follow-up has come out, which is that folk have looked at what happened to the patients in sprint 9 or 10 years later. And it's quite interesting. And what it does is it reflects on our care. So if you look at the graph on the right, you'll see that the trial during which all the work and all the data was accumulated is the first 2 to 3 years. Then they followed the patients out without really being in the trial. They were allowed to fiddle around with treatment, fiddle around with control, according to the clinicians who were looking after them. And the end result is that if you stop being excited about all these things, all the differences start to fade away. So it's important to think about that, and that tight blood pressure control means tight blood pressure control carried on for decades, not tight blood pressure control carried on for a year or two. To accrue these advantages, you have to be fairly strenuous. And in real life, it's not always that easy. And we can certainly discuss some of the reasons why that isn't the case in real life. But moving on to something more fun, what can you do for blood pressure control? Well, we've got 3 medications, a thiazide, amlodipine, and an ACE inhibitor, and they all do exactly the same thing in terms of being effective at lowering high blood pressures. And we have all of those things available. The thiazides, as you know, are relatively effective. There's no difference, as we now know, between chlorthalidone and hydrochlorothiazide and the others. So don't feel you've been left out if you have to use HCTZ. It's fine. And we do have access to an ACE inhibitor and a calcium antagonist. Just a few points about amlodipine. Remember that if people are on simvastatin, you want to be circumspect with dosing of the simvastatin, because the side effects of rhabdomyolysis and achy muscles come on if you increase the dose much beyond 10 or 20 milligrams if you're on amlodipine. That's a drug interaction. It's just worth knowing about. Amlodipine commonly causes leg edema. The trick is not to put people on high-dose furosemide. That may get rid of their edema, but it's not great for the patient or their kidneys or their postural hypertension. And a better strategy is often to try adding an ACE inhibitor to those patients if their blood pressure allows it. And then be wary of calcium antagonist and beta blocker combination. Again, not going to spend much time talking about, other than to remind you about hyperkalemia as a side effect and looking at a creatinine a few weeks after starting therapy just to see it hasn't screamed up. an interesting little study that came out a couple of years ago, observational thing, found that in fact there wasn't actually any loss of benefit, and perhaps even more benefit in folk who had a creatinine rise. So it's still a little bit open to debate about what you should do when the creatinine does creep up a little bit. And generally speaking, if it's gone up a modest amount, it's probably reasonable to keep an eye on it and keep going. I just want to detour slightly, and this is the last slide on hypertension, and talk about what happens to those folk who pop into your clinic at the end of a busy day, having done their shopping, and thinking they'll just go and get some refills of their medicines, which ran out a couple of weeks ago. And they'll be sitting there with a happy smile on their face, a big bag full of shopping, and a blood pressure that the nursing staff have got all round-eyed about. This is an observational study, so don't read too much into it. But essentially what they showed was that in the group who they sent home, who had average blood pressures of about 180 systolic, the chance of an event in the next 7 days, or in fact in the next 6 months, was no higher than the group who had slightly higher blood pressure and for some reason were admitted and were then hospitalized while the blood pressure was brought under control. But that's not to say you don't want to take it seriously. It's that there's warning signs that things are going wrong. And most of those warning signs, headache, shortness of breath from the pulmonary edema, hematuria, fungal changes on retinoscopy. But in the absence of any of those things in a well patient, it isn't absolutely essential to admit such a patient and put them on IV therapy. We can also debate that if you want to. I'm going to move briefly on to lipids, and I'm not going to spend any time on this slide other than to show that it's got big red things, and that's scary. So let's look at that. And this slide looks at it slightly differently. So this slide shows you the absolute benefit in terms of LDL reduction if you are at low risk versus high risk. So if you look at the slide, you can see that these risks are in hundreds, but in fact, if you change them into percentages, the chance of a major vascular event in 5 years, if your risk is relatively low, is about 7 or 2%. Whereas if your risk is high to start with, then there's an appreciable benefit from starting a statin and lowering the cholesterol. So it's all about benefits you're going to get. And this is displayed here. If you have a non-diabetic woman with a 10-year risk of 10%, and you stop her smoking, you'll halve her risk. If you put her on a lipid-lowering agent as well, you'll drop it from 5% to 4%. But those changes are markedly different in an obese male diabetic who's under 75, depend on baseline risk and are important to discuss with patients. If you want to do it with a more fun, real-life way of doing it, there's a site you can go to. But if you just Google Q risk 3, you'll get to the site. You can fiddle with adjusting these risks and seeing what happens, just so you understand what these changes mean. So when to give a statin, secondary prevention, diabetic for more than 10 years, or diabetic who's more than 40 years old. We all know those ones, but remember that you want to be a bit careful if you don't have other risk factors. Not everybody needs to be on a statin. And just like aspirin probably isn't indicated for primary prevention in our practices, even though it seems to be very prevalently used. So let's get back to our patient. Have you looked at his JVP? And the short answer is, well, maybe. But if you look at the study from Ireland, they actually found that 75% of patients treated with diuretics or fluids had no JVP assessment. is all I can say. It is worth looking for, but when it is visible, it does. And there's all sorts of exciting things you can find, which I'm not going to go into now, other than to say that most of the JVP waveforms you see are CV waves. And if you start to look for them, you will see them. And the other one that really is exciting because it helps you make a diagnosis is a prominent X and Y descent. So if everything looks like it's very exacerbated and very clear and well-defined, it may well be that you're looking at a prominent X and Y descent of somebody with constrictive pericarditis. That's what a dilated cardiomyopathy looks like on echo, and it's a very straightforward diagnosis. I put this slide up not for the echo, but to remind you that if you put your hands on the heart and you put 3 fingers next to each other in one interspace, and you can feel the heart with all 3 fingers, you've probably got a volume-loaded apex, and you've probably got a dilated cardiomyopathy if there isn't organic mitral valve disease. So it's quite easy to do. And you don't need to be an echo expert to do it either. And the patient with the dilated cardiomyopathy is the one who's going to benefit from all these drugs. But anyway, let's look again at these fancy signs. There's sensitivity and specificity issues. A lot of these signs we taught have sensitivity of less than 50%, and they're all fairly specific if they're present. But if they're not there, it doesn't mean that the patient doesn't have the condition. Mitral stenosis is the one that's often missed simply because one doesn't listen for it or think about it. And again, it's well worth thinking about it before you put somebody to sleep for their cesarean section. And again, touching your hands to the heart may well make you feel that quite characteristic sort of apex, but you have to have felt it a few times first. So feel around for them and really look for an apex that's going to talk to you. Mitral regurg, again, we've discussed it already. Listen for it and you'll be surprised at how often you hear it. And then let's talk about the treatment of heart failure, and then I'll move on to something more fun, which will be chests. But basically, if you've got a cyanose patient, swollen legs and a raised JVP, think about cor pulmonale. If they've got clear lung fields and increased cardiac shadow and swollen legs and a raised JVP, think about pericardial disease or cardiomyopathy with clear lungs, which is there if they're not in pulmonary edema. And then if you pop your stethoscope on the chest and you hear murmurs, you may have a valvulopathy. If you pop your fingers on the apex and it's volume loaded, you've probably got a dilated cardiomyopathy. And if the apex is palpable but very well localized and increased in amplitude, you may well have a preserved ejection fraction heart failure thing where lifestyle modification is the main way forward. And the issues around that are used for dilated cardiomyopathies, it's ACE, spironolactone, and carvedilol. They all improve mortality or reduce mortality, so all worth doing. And I'm not going to spend time on them other than to remind you that if you have a patient with these conditions, it is worth trying to get them on all 3, but you have to watch out for renal issues and introduce things slowly in some patients. The absolute mortality benefits are there, and it really is worth remembering this. So get them onto those agents, and hopefully they'll do well. This is the last slide on heart failure. This is something new which we picked up in the EML while we were reviewing a chapter, and it was rather disconcerting for a lot of us to find reasonably clean evidence that morphine is not a good thing to give to people with pulmonary edema. There's a clear signal of harm and there's no signal of benefit whatsoever. So try and avoid using it in patients with acute pulmonary edema now rather than rushing into giving it. Pericardial effusion, easy enough. That's characteristic chest X-ray, and sometimes with a pulsus paradoxus, which is a changing in amplitude of your pulse, depending on whether you're breathing in or out. And it is really worthwhile making that diagnosis. That's what it looks like on echo. And the one on the right is an exudated pericardial effusion. In our practice, it's usually tuberculous. Occasionally, it's malignant. But it is really, really worthwhile making the diagnosis because it's a completely treatable condition. So let's move briefly on to something else, which is asthma and COPD. And this is a sort of very common story. Intermittent salbutamol prescriptions now comes in with a cough productive of green sputum and some edema of the ankles. And probably the diagnosis is going to be COPD and cor pulmonale rather than true asthma. And you can see from the upper lobe fibrosis that she's had previous TB. She's got flattened diaphragms. And that's to be distinguished from true asthma, which is a younger person, sometimes with a chronic cough, never been labeled as wheezy, and got other illnesses that everybody pays attention to and forgets that he's unable to work because of his limited effort tolerance, and his chest may even seem clear on auscultation. So the key investigation there is a peak flow, which is easy enough to do. Remember that when you're counting ribs, you have to count right from the top. There's one right over there, and when you've got down to the bottom, you can sometimes see the 12th rib, but don't miss the first rib, which is hiding there. And all that wheezes is not asthma. So there's heart failure, there's foreign bodies, there's extrinsic compression, and there's valvular heart disease as well. Do think about nocturnal symptoms, do a peak flow, and think about a pneumothorax in patients with asthma who are suddenly distressed, but be careful of sending them out of casualty for an X-ray. Bring the X-ray machine to them if you can. Remember this chart, it's really useful. Try and put people onto the peak flow chart, what they expected to be blowing as an outpatient, not what they seem comfortable with. Oh, are you feeling better now? Is not enough. You want a peak flow recording, just like you want a blood pressure recording for somebody who's hypertensive. And remember that you can ask these questions, and it's all very important to try and find out about difficulties getting to and from work, feeling perceptions of shortness of breath once a day versus twice a week, waking up at night, using rescue nebs, and just a sort of general sense of how people feel about their asthma. So getting that scored in and done is really important, and we want scores of 19, 20, not scores of 2 or 3. Nebs, reassurance, and steroids are the mainstay of treating acute asthma. You all know that. Please avoid theophylline. Don't give furosemide, and magnesium is not a wonder drug. I'm happy to talk about that, but it's probably not the be-all and end-all in asthma control. How to prescribe a salbutamol neb. If you dilute 5 ml of salbutamol in 4 ml of saline and nebulize it at a flow rate of 6 liters a minute, it'll take about 15 to 20 minutes to finish the neb, which means that you can pop another one in when that's finished and keep going and give about 15 milligrams an hour, which is the sort of maximum dose. If you give them undiluted, it's sort of okay to do that, except that if patients want continuous nebs, then they quite easily can get a bit too much and get very, very anxious. The alternative is to put them just on oxygen and stop the nebs, but patients don't like that when they're feeling very tight. So running the neb with a dilute bit of salbutamol in it makes more sense in terms of safety and makes patients feel a bit better. When you've got them in the ward, remember to check their peak flow. And they often get worse in the ward after they've been admitted because people forget to give the nebs and they forget to give the steroids, and they certainly don't chart the peak flow unless you ask for it, and make sure there's a peak flow meter in the ward that is usable. All of those things really do make a difference to management of these patients. Discharge is about making sure that patients understand what's wrong and that they need to be on a steroid inhaler, not maybe, but definitely, and that steroid inhaler is now going to be for many years simply because they were admitted. And they need to know their target peak flow and that they must not run only on short-acting beta agonists. So moving briefly on to COPD, this is about asthma that isn't reversible. In other words, they wheeze, they get a bit tighter when they wheeze, but they certainly don't return to normality between wheezing episodes. Again, there's a scale, and it's worth just looking this up if you haven't got it on your phones or wherever, and remembering that folk who are too breathless to leave the house or get breathless when they're getting dressed or can't walk more than a few minutes on level ground are really in trouble and really haven't got a great deal of reversibility. And if you look at this in terms of prognosis, 3-year mortality when you've got scores of 8, 9, 10 is sitting at nearly 30% air conditioning. Good things we can do for these patients, but it is important to counsel them and understand that it doesn't always do well. Just some of the signs you can look for, and just a reminder of their sensitivity and specificity. Hyperresonance is actually not always present, but if it's there, it's obviously very helpful. Hoover's sign, that intercostal retraction, again, not always present, but not too bad. Remember, the laryngeal height is from the suprasternal notch to the top of the thyroid cartilage. And if that's less than 4 centimeters, you've got high likelihood that something's going on in terms of hyperinflation. But again, it's insensitive. Only about a fifth of patients have that. And the good one is listening for forced expiration. If it takes them more than 6 seconds to breathe out all the air in their lungs, then that's highly sensitive and highly specific for COPD. So again, how do these signs perform? And they're all up there in terms of specificity and all down there, except for a history of smoking in terms of sensitivity. So again, they're great if they're present. Don't assume they will be present in every patient. Management, as you know, fairly straightforward: oxygen, steroids, antibiotics for flares, and NEBs with salbutamol. And just a couple of tweaks on this. Sometimes you're worried about whether people have got bullous lung disease with great big bullous at the top of the lung or on the side, and whether it's that or a pneumothorax in somebody who's got COPD and seems more distressed than usual. It is worthwhile popping an ultrasound on their chest if you know how, because if you do find lung sliding and no beach, then it is useful to use that as part of your workup strategy. So what to do if those folk have got quite severe COPD? Well, it is, as I say, a condition that some people regard as palliative, and certainly you should be starting to counsel people about the fact that they're not going to improve in spite of all your fancy medicines. They're not going to get normal again. And do look out for inhaler dependence. You know, when they're puffing away on these inhalers every 5 minutes, they feel toxic, feel terrible, and actually probably get very little benefit from them. But avoid theophylline. It's really a drug of the past. Very seldom you should be giving it, and probably only in consultation with somebody who's got some experience with its use. Home oxygen story, we can again talk about that, but again, with load shedding and all of the sort of things that are happening these days, it often leads to people coming into hospital more often when their oxygen runs out than it does keeping people out of hospital. And then I just wanted to remind you, here's the theophylline one showing increased mortality in the small studies that have been done. It's not dramatically good evidence, but just like morphine in cardiac failure, it's a drug that has a signal of harm, not a signal of benefit. When you get the folk with COPD who are overweight and quite heavily cyanosed and look sort of Pickwickian, and they come into casualty, you've got to be careful of overdoing the oxygen. They often get bunged onto oxygen as soon as they hit the casualty, and they look a bit distressed, and then 10, 15, 20 minutes later, they seem to have calmed down and even be dozing off. Remember that that CO2 retention can be a major problem for these folk, and it ends up as being literally a sedative, and they end up with CO2s of 11 or 12. And so remind yourself that safe SATs in these people are probably between 88 and 92%. If they've got SATs of 97%, they've probably got CO2s in the sky if they're comfortable and drowsy. So sometimes just taking the oxygen away will do them a favor, or reducing it to a lower flow mask. So I'm not going to spend time on home oxygen therapy, but just to show that the data on its efficacy, it's taken as a proven good. But again, the studies were tiny and not a terribly good quality. And some of the newer studies looking at supplemental oxygen in people who've got reduced SATs when they start to exercise show even less benefits. So it's a thing that's there, and in rural practices, it's not necessarily a disaster if you can't get your hands on it. Okay, I'm going to move on. I'm sort of nearly finished. I know I'm going quite fast, but I'm going to move through a few things there. I've only got 2 slides on this, and they're really just a reminder that saying that Koenig's and Brzezinski's signs are negative is a fairly pointless exercise when their sensitivity is 10%. So 90% of people with meningitis have negative Koenig's and Brzezinski's sign, and eliciting them and talking about them is probably one of those corners that is very worth cutting. And save yourself a bit of time. Do some neck stiffness testing by all means. Look for a jolt sign, which is when you shake your head from patients shakes their head from side to side, they get a worse headache at the extremes of motion. Those things mean more and are more sensitive than the 2 antiquated signs from TB asylums in the 1900s. The only other thing I want to say about meningitis is beware of the early polymorph predominance. Sometimes they have low glucose, high protein, look like a bacterial meningitis with high polys and very few lymphs. And if in doubt, because they're not settling down or you're a bit worried about them, don't be afraid of repeating the LP, and particularly if there's some evidence of TB elsewhere. What about strokes and hemiplegias and subdurals? Again, a lot of the stuff seems to be based on the history. And if you take a decent history and there's an abrupt onset event, it's probably not a subdural. The problems arise in people who've abused alcohol and been found unconscious. And sometimes looking in the fundi can help you. If you see papilledema in an unconscious patient with a hemiplegia, it's either a big bleed, intracerebral bleed, or a subdural, and in that case may well warrant a CT. What about the basics of stroke care? Speak to the family and to the patient. Give an aspirin, test the swelling, think about incontinence, bed sores, dehydration, and don't overtreat that initial blood pressure. So the issue that comes up here is about airway protection. And one of the things that happens is that we have elderly patients who have lots of other comorbidities and are deeply unconscious after an abrupt change in condition at home. They've probably had a big bleed or a big stroke, and their prognosis is extremely poor. So tubing and posting them is not necessarily medicine, and counseling the family and trying to explain what the prognosis is may well make, and again, can chat about that. Remember that putting a tube into any patient can cause a hypertensive surge. And when the tube wants to come out because the patient now is a little bit more awake, you end up sedating them, and then we go in a circle. So think about whether the intubation is necessarily of value to that patient. It's not to say patients shouldn't be tubed before being put in an ambulance, but just think about which ones will benefit from it. Remember that in young people, you want to do quite sure that you've checked out for things like Takayasu's by feeling the pulses in both arms, not just the one side. Listen for murmurs, and don't forget to do syphilis serology. We've got a bit of a little epidemic going on at the moment. ANA, HIV, and hyperviscosity syndromes. Check the full blood count. See they haven't got leukemia. All of those things are easy to do and well worth doing in a clinic, or in any institution where you encounter a young person with a stroke. The stroke indications for CT are also somewhat moot, but would be almost certainly if there's a difficult history, if there's preserved consciousness and a neck stiffness, if you're worried about a posterior fossa bleed, or if you've got somebody who's presented hyperacutely and thrombolysis is a possibility. Thrombolysis is something that seems to be more a goal than something we can achieve at a district hospital level. Absolute reduction in death or dependency is 4%, no difference in mortality, and only about 5% of patients around the world who present are really candidates, depending on what your ambulance service is like, of course. Remember to give them some aspirin, some statins, and don't overdo the blood pressure reduction when you first see them. So if you look at this trial, it was CATUS, which was a big trial of 4,000 people from China, where they aimed for either tighter blood pressure control with starting antihypertensives to aim for a blood pressure of 140/90, or letting the blood pressure settle by itself. And there was no difference in clinical outcomes, which is important to remember. So just because somebody's got a blood pressure of 180 doesn't mean you must charge in with antihypertensives. And then I think this is nearly the end, but aspirin and the risk of early recurrent strokes. The most of the benefits, and it is huge, is in the first 6 weeks. After that, thin. So watch out for these patients, but giving them the aspirin early really makes a difference. And not giving aspirin to somebody who's had their third GIT bleed after a stroke 10 years ago is probably not is probably something worth considering. The size of these absolute benefits is also small. Remember that it's down here. So your chance of a recurrent stroke drops from 2.5% to just under 2%. It's not a huge benefit, but it is big in that first 6 weeks. All right, I've taken you on a roller coaster, and I've deliberately gone fast to leave time for people who want to ask questions or discuss things or give other viewpoints on any of the issues I've raised. And I really do think you guys have a huge chance of making a difference where you are. Good notes and attention to your exam really makes for reassurance for yourselves and your colleagues and the patients. And the clue is think and listen and examine and think again when you prescribe. So if you do all those things, you really should have fun and really help out your patients quite a lot. So enjoy, and I'll stop then, and we can now take any questions or discussion if you want to.
Thank you very much, Andy. I think that's just stimulated lots of things that people are wondering about. There are 2 questions in the Q&A. I don't know if you're easily able to see that. The first question is a question from Dr. Boshoff on heart failure. What is the approach when one is a patient in heart failure and worsening renal function? If you have some top tips for us on that.
Sorry, in terms of whether you don't know their renal function yet, or you've got it and you're worried about it?
Sounds
I think
like
those are slightly different things. If you don't know, sorry, the line went a bit funny there. I didn't hear you.
No, I think it's a patient with heart failure where the renal function is going down. So you've got a patient with heart failure where the renal function is probably under.
Yes. Okay.
Under
so Yeah. So the first thing to remember is that your GFR estimation is based on a thing that we all forget about, which is that your patient must be in steady state. So if you're bunging diuretics on patients, or their blood pressure's all over the show, or they're going in and out of heart failure, they're not in a steady state in terms of renal function. And the GFR calculation becomes, to a large extent, uninterpretable or very difficult to interpret. The main problem is that heart failure patients underperfuse their kidneys for the reasons they're in heart failure. It's all to do with aldosterone and angiotensin and all the happy things that you were taught at med school. But the bottom line of it is that adding a vasodilator to somebody and improving their heart failure often causes the urea and creatinine to improve. And it's quite gratifying, because that's actually a sign that your cardiac output is doing good things and that your patient's improving in general. So the worry is when the heart failed, or when the urea and creatinine keep on going up even with treatment, and that often means that you're over-diuresing a patient at the expense of using the other agents. Sometimes just cutting back on a diuretic actually improves the state of play and is worth considering. But in general terms, those folk, try and get them on an ACE inhibitor if you can. They're often fluid overloaded, so you're a bit scared of your beta blocker. Once the creatinine's up above 160, 200, you're probably a bit nervous of spironolactone. You essentially end up balancing an ACE inhibitor and your diuretic, and it can be a bit tricky, but it's well worth a shot. And if in doubt, phone a friend and let's see what we can do to help you with that sort of thing.
Thank you. The next question there is on asthma and COPD, a question around the asthma COPD syndrome concept. If so, what is the prevalence and how do we approach management? And Andy, I wonder if you also want to add a couple of words in terms of, we've got the salmeterol, we've got the combinations now of the budesonide formoterol and the salmeterol,
Formoterol.
So we have these new combinations with the steroids and the low, and just some ideas in terms of the use of that and these patients where the asthma COPD seems so mixed.
Yeah, I mean, it's like all these things. There's always a new buzz and something very exciting to get interested in. This concept that you can have a mixture of the two is obviously and unsurprisingly fairly real. It doesn't actually probably make that much clinical difference, because essentially what you're wanting to do is to optimize care for an individual patient. And the main thing with that is to manage bronchospasm if it's reversible. And that's why I gave you two extremes in terms of the patient. So that young guy should be cured of his asthma. That's your goal, to make sure that he never gets tight, that he gets himself a job, and that he doesn't cough at night. And that's the aim on that end of the spectrum. And the other end of the spectrum is a person with irreversible COPD who may or may not wheeze a bit, but in fact doesn't have much of a bronchodilator response to therapies. And for instance, if you check their lung function, and you can all do this, you can, if your hospital hasn't got a handheld FEV1, FVC meter, just ask them. It is usually possible, and it's floating around somewhere, and it's not difficult to do. And they're actually relatively cheap now. They come in at under 1,000 Rand. So it is worth trying to get one of those. But the bottom line then is, if you're not reversing, then you're probably towards the other end of the spectrum. And there's going to be people in between. And that's really the idea, that you really don't want to condemn people with COPD who have got reversibility, and you don't want to over-treat people with a label of asthma who in fact are heading more towards the COPD end of the spectrum. If you leave asthma untreated for long enough, it does end up behaving like COPD. As far as the inhalers go, the steroid inhaler separate to a beta-2, short-acting beta-2 was the traditional thing that we used for some time. The EML has now accepted that combining the two and giving a long-acting beta-2 stimulant and a steroid in the same puffy machine makes a lot of sense. So depending on tenders and things like that, we'll either have the salmeterol or formoterol as the long-acting beta agonist and one or other steroids. The steroids for practical purposes are interchangeable. There's nothing in it. The LABAs, there's a lot of buzz going around about which one is better. The salmeterol is older and has got more studies on it and more studies on safety, and they picked up a few signals which they didn't find with formoterol, simply because the formoterol studies are almost an order of magnitude smaller in terms of numbers. So formoterol has got a reputation of being safer. Be that as it may, I think at the moment we more or less have to take what we can get. Remembering that formoterol is sold as something you can add a short-acting beta-2 to. So just because you've taken your long LABA doesn't mean you can't take a short-acting one. But generally speaking, you shouldn't be needing a lot of short-acting beta agonists if your patient is being properly managed with a longer-acting one. And there is data, as you probably know, that you can just take an extra puff of the LABA as a reliever now. So these things are in there and are very well worth using. They are not cheap. And it's one of those sort of surprising thing that we've managed to put into the country. It's a heck of a lot cheaper than buying those things from a private practitioner, but they still are fairly pricey agents, but really, really worthwhile. And we're quite proud that we've managed to get them into the public sector at the prices we have. If you think you're saving money by putting people on theophylline, you're not. Theophylline is more expensive nowadays than some of these inhalers. The main thing with them, though, is to ensure that people know how to use them. I get very sad when I see somebody taking one of these state-of-the-art inhalers and really the people looking after them haven't bothered to explain how to use it. I even saw one the other day who tried to take it with a cap on. And so there really is, don't rely on the pharmacist. If you've ordered one of these things and you've got it, make sure the patient really does understand. They are a little bit tricky. You sometimes have to read the instructions yourself because they differ and they are not straightforward to use, but they're certainly worthwhile.
Thank you very much. In the handy reference tools that'll be sent out, and tomorrow in the resource pack, there's a link to some handy reference tools. And in the ones on asthma and COPD, there's actually little QR codes that you can scan if you're a patient on how to use, especially the little turbo halers, which is not so familiar to us. There's quite a few questions. So the next one, I think you can just do a quick yay or nay. It's a bit like the somebody in a question on the use of digoxin and CCF.
I've been practicing for too long to give a yay or nay to that. For practical purposes, it's nay unless you've got somebody who you can't give a beta blocker to manage their atrial fibrillation is the short answer. I still quite like to use it in very selected patients, and it's probably swinging back again. It swung right out of the park a few years ago, but it's like all these things. You probably don't need to use it.
And then there's a quick question about the hypertension guidelines recommending the use of digital blood pressure measurements. I'm not actually sure if that's true. I'm not sure if you know, Prof Parrish. I know they talk about having machines that's been calibrated, but do you have any preference for digital over manual?
Yeah, so the data is in for a well-calibrated new digital machine that is being serviced regularly and is being used properly. It is probably better than manual ones where there is a bias. We get biased in terms of how we take the blood pressure. So it's slightly more accurate than the manual ones. The problems come when you get poorly calibrated machines or very old machines or machines where the batteries are on the blink And in those cases, it's really worthwhile thinking about whether you are accurate at extremes. So the machines are designed really to take normal blood pressures, and some of them are wildly out at the extremes if they're poorly calibrated. We're doing a little study on it at the moment. It's quite alarming. The blood pressures are literally out by 40 or 50 millimeters compared to the machine when you take it with a newer machine. So they do need to be looked after properly.
Thank you very much. Then there's a question about if one is not using morphine in acute pulmonary edema, and what alternative options do we have to keep the patient calm because they tend to be restless?
Yeah, so the best option is to get them out of pulmonary edema, and doing that is the straightforward answer, and giving them enough furosemide and enough nitrate, if you think that's going to benefit that particular patient, is probably the way to work. They work fast, those things. They act as furosemide is a venodilator, the nitrate's a vasodilator. So you start to get action within 10, 15 minutes. And so as I say, the morphine, we're not sure why it's dangerous, but it's probably because some of the patients have heart failure plus COPD, and may end up getting a bit of respiratory compromise. But the bottom line of it is that, I haven't used this stuff for a decade or more, oddly enough, and I don't feel the absence.
Thank you. There's a quick infectious disease question, infection around meningitis. So this is a question about admitting a patient with unspecified meningitis. So you're obviously suspecting meningitis clinically, and whether to cover early for TB if results might be delayed. So if you've got a 25-year-old female RVD defaulter admitted late on a Friday afternoon with a clinical picture of meningitis, the bloods or CSF is only going to be taken to the lab by courier on the Monday morning, whether you would start TB treatment early on, as well as the 2 gram of KEF that you'll be giving while you wait for that LP result. Is there urgency? It looks like they've had poor outcomes with patients where they've been where they started the TB treatment late for TBM.
I think that this is one of the sadnesses I've got about clinical medicine in the last 20, 30 years. In my day, when I was an intern and just starting out in a district hospital, we'd think nothing of staining that CSF and having it look at it in the middle of the night to see if it was lymphs or polys. So, that's the sadness, unfortunately. The short answer is that it's context specific. So if you get somebody who's coming in with a fulminantly acute history, it's probably bacterial, but can be TB sometimes. If you get somebody coming in and saying they've been headachy for the last 2 weeks, then almost certainly it's worth covering them for TB. But you can do the other bits and pieces. So feeling for the lymph nodes, doing a urinary lamb, looking and seeing what's on the chest x-ray. If you are of that mind, popping an ultrasound probe across the spleen and picking up some holes in it. All of those would be things pointing to you towards TB treatment. My gut feeling is actually, if you're in doubt and you really are unhappy about it, it's not unreasonable to start TB treatment early. But generally speaking, if you're giving bacterial, KEF trioxide overnight and the patient's grinning at you the next morning, then obviously there's less urgency.
Thank you. The next question is about how does one approach ventricular tachycardia secondary to salbutamol nebs in a severe asthma attack? So if you have somebody where you've slightly overdone it with a salbutamol, is there anything one can do for that tachy?
They're usually not ventricular tachycardia, supraventricular tachycardias. If they are broad complex, they're probably aberrancy. The approach to ventricular tachycardia is quite straightforward. If they drop their blood pressure, you shock them. If they haven't dropped their blood pressure, you can try whatever fancy muties you've got available. But generally speaking, they're SVTs. And the key thing there is to remember that a combination of salbutamol and hydrocortisone and sadly theophylline all tend to lower calcium. So think about that as another option, that they might be hypokalemic as well. and that fixing that tachycardia without fixing the potassium can be problematic. But generally speaking, it will settle. If you have adenosine, you can use that. If you haven't and they're not settling down, shock them again. Shocking somebody with asthma is really not a fun situation because they usually end up needing a ventilator or at least intubation in the short term. So adenosine is fine. I mean, it's not great in asthmatics, but there's not much else. You can think about verapamil perhaps, but its success rate is only about 30%.
Thank you. And still on the lungs, there's a question here about the use of beta agonists in COPD patients with a history of col pulmonale. For example, they've had a previous hospitalization for that.
The long-acting ones, yeah. I mean, that's fine. Either a long or a short-acting one, whichever you can get your hands on, is probably reasonable if they are showing a response. And again, that comes back to the concept that if you can't measure the response, it's sometimes difficult to say because patients tend to say they're feeling better when you're seeing them in outpatients than when you discharged them with the inhaler. So, it's difficult to do unless you quantify it in some way, and trying to measure peak flow is not always easy, and particularly with PD patients, they don't seem to have much difference in peak flow sometimes. So looking for some measure of FEV1 and FVC, if you can, would be great. If you can't, all you can do is take the history and use one of those scales and see if you think it's helping them. And if it's helping them, carry on with it.
Right, and then we've actually on the last couple of questions, which is around stroke. From the same person, there's a question first about using aspirin. So if you've got a patient in the district, you're not always going to know if your stroke is ischemic or hemorrhagic. Would you routinely start that aspirin? And then the second question is if there's a need to wait for renal function when you're discussing a patient for CT scans. If you're going to send them off to your tertiary hospital with an acute stroke, can they just do a non-contrasted CT, or do they need a renal function before they scan them before you send them in?
Okay, so the one about aspirin is interesting. We have put it in the EML. There was a study done by, well, it was a modeling study looking at the Chinese and other original studies that came out on the use of aspirin. They had a huge number of patients. I can't remember if it was 20,000 or 40,000. And inadvertently in that group, they had a bunch of people who, for various reasons, got given aspirin even though they'd had bleeds. And the numbers were quite small, so it isn't hard and it's not clean evidence. But basically what they showed is that the most likely second event in somebody with a bleed was not another bleed, but a infarct. And the aspirin does help those patients. It reduced the chance of them having an infarct, just like other patients who'd had a first infarct. The issue is it does increase bleeding risk or chance of bleeding, but the benefit seems to be neutral to possibly slightly in favor of reducing infarcts. So the modeling study effectively said that in a resource-constrained environment, and they were talking about Africa in general, where you can't access CTs, giving aspirin to everybody with a stroke probably was a reasonable thing. Now, there are limits to that. And like all these things, you just got to be a bit careful. So somebody's got a splitting headache or somebody who's been on warfarin, or somebody's got petechia all over their skin. Clearly, you're not going to give those ones aspirin. But all things being equal, it's probably not unreasonable to give them an aspirin, recognizing that some of them will have a rebleed, but overall there will be benefit. The issue around contrast and people who say you have to have a contrasted scan, it boils down to why you're sending them for a scan in the first place. If your question is, has this patient got a subdural, then you should be sending that patient anyway, and an uncontrasted scan makes sense. If you're investigating a young person who's recovered completely and is just got a weak arm or something like that, and you're wanting to make sure that they haven't got aneurysm or something of that nature, then clearly having somebody in renal failure will delay the process because they will need contrast. But generally speaking, we're not as excited about contrast nephropathy as we were some years ago. And I wouldn't be particularly inclined to delay sending a patient like that. They should be fixed at this end rather than at that end.
Thank you very much. And there was just a last comment, which I think you've already mentioned, is the fact that aspirin and primary prevention does not really have much of a place. We are constantly stopping patients coming in from clinics on their aspirin just because they've got a blood pressure or a bit of diabetes. And we really need to preserve that for our secondary prevention patients. I don't know if you have any last comments like that on that, and then we can wrap up if you have any last words of wisdom.
Yeah, no, thanks. I mean, we've discussed that already, so I won't harp on it again, but it really is something worth doing. I mean, I've made this concept that you want to look for harms when you're prescribing, and rewriting somebody else's irrational aspirin prescription isn't rational. So it doesn't help them, and it does cause harm in terms of bleeds. And so it is worth stopping primary prophylaxis. There is a slight benefit, but it's at least equaled by the increased bleeding risk. So even in the US, it's frowned upon. So just don't use it in that situation unless there's a clean indication.
Oh, thank you very much. You can hear from the questions. We've covered so many different areas, and I hope all of it is just making our daily practice just that little bit better. And it's also inspiring us just to go and read and go double check things. And I really want to encourage you to look at the BAMSI site. I've put the link in the chat earlier on, and also it will be available in your packs tomorrow. And there's lots of presentations where Prof Parrish just focuses, for example, on heart failure or focuses on stroke, etc. So thank you very much. And I see already lots of positive feedback coming from the poll and from the different chats. There is a poll out there. Please try and fill it in if you're able to. Otherwise, just make sure that your name is in the chat. Thank you very much, Prof Parrish, for spending this evening with us. And we hope you have a good rest of the evening.
Great, and thanks for listening to me. And I really hope you all have a wonderful further career in their rural areas. Enjoy. Cheers then.
Thanks, everybody. Bye-bye.